Good afternoon and welcome to today's suicide prevention webinar. Thank you for taking the time out of your day to join us. We're very lucky today to welcome two guests. Dr. Chloe Beale from East London NHS Foundation Trust. She's a liaison psychiatrist and recently wrote a paper titled, the title of today's webinar, Suicide Prevention, Magical Thinking and Moral Injury, Exclusion Culture in Psychiatry. In the chat box you can see a link to it. I would recommend you read it. It's a very thought-provoking article and one that was all good to read and think about, really, hence today's webinar. And also Linda Thompson, who some of you will know. She's a peer support worker working with our Oxford crisis and home treatment team. And she has worked with the STARS programme and done lots of sort of work, certainly with me and with others, around suicide prevention locally. So today's webinar is going to be slightly different in that we're going to have very much a discussion-based session. So in a minute, I'm going to ask Chloe to sort of talk us through her paper and her reasons for writing it. And Linda's going to share her perspectives and experiences in her own experience and also as a peer support worker. And the aim of today really is to start our critical thinking around language and culture and exclusion culture. Those of you who were here last week will recall that that's one of our strategic objectives, is to look at language and culture in relation to suicide prevention. So what we'd like you to do is to start putting questions in the chat box as soon as possible, and we'll incorporate them into the discussion. So without further ado, Chloe, thank you. I shall pass over to you and wonder if you could perhaps start off by talking us through your article, and we'll take it from there.
Thank you, and thank you very much for inviting me. Actually, a sort of a minor correction to start with is that it's called Magical Thinking and Moral Injury, etc., and not anything to do with suicide prevention, though quite a bit of the content is about suicide prevention, and that's part of where it arose from, because as well as being a liaison psychiatrist, I'm also my trust lead for suicide prevention, and it's an area that I'm very interested in. So it's not specifically about that, but there's a lot of overlap. And the article is really about the ways in which we exclude people from getting care in mental health services. So in it, I talk about the ways in which we sort of exclude people on an individual basis by coming up with reasons for why somebody is not in need or indeed not deserving of care. So things that we say about people being low risk, for example, or having capacity to kill themselves, which is certainly not anything that is endorsed by any sort of research or guidance that I'm aware of, but which I'm very well aware that a lot of patients would tell us it has been their experience. And it's also about the way our systems are designed to exclude people. So we talk about gatekeeping and protecting beds, and all clinical services have, have exclusion criteria, and we tell people that they can't access treatment because they've got the wrong diagnosis, or they are not showing appropriate commitment, or they need to take responsibility for themselves, or they're in the wrong postcode, or they need to sort out their drug and alcohol use first, or any other sort of myriad reasons that we use as sort of excuses to keep people out of services. And I think that what I would argue is that we need to be more honest about the reasons we're doing this. And I think we kind of kid ourselves that what we're doing is something clinically appropriate, when actually it has much more sort of sinister undertones. We prevent people from accessing care because then if bad things happen while they're under our care, then we might get blamed. And so we're actually, as clinicians, we're frightened of our patients. We prevent people from accessing care because we haven't got enough of it, and services are completely overloaded. But instead of being honest and saying, look, we want to offer people things, but we can't, we sort of invent reasons for why it's definitely not the right thing for this person. So really the article is sort of a plea for honesty, and let's just actually name what's in front of us and what's going on, which is that we don't have enough resources for everybody. We are protecting ourselves and protecting our own backs half the time because of fear of what will happen if, I don't know, X, Y, and Z. You know, the obvious thing is if somebody ends their own life, but instead of sort of thinking I need to try and prevent this because that's, you know, that's the ethically, morally, clinically right thing to do, we sort of think, oh, what if somebody dies and, you know, and I get blamed. So the reason I wrote the article was a sort of a you know, a culmination of a lot of frustration. I'm a liaison psychiatrist, so I spend my life writing referrals to every service you can possibly imagine, and at least half of that time having arguments as to why I really do think that I've made the clinically appropriate decision, and then coming up against bed managers and home treatment team managers and service managers of all sorts of other services trying to say all the reasons why they think they shouldn't possibly be expected to take my referral. And so it's a sort of a scream of frustration, really, the article. But what I have found since it was published online is that it's resonated with a lot of people, which is really good in lots of ways, that lots of clinicians have contacted me and said, oh my goodness, thank you for saying this, really agree, really recognise this. But in some ways I find that worrying, because I think that if everybody recognises this and people agree, why is it still like this? And one of the things that has been really heartening as well is lots of patients and carers have contacted me to say how glad they are that, you know, a psychiatrist has said some of these things. And of course, this nothing that I've said is anything new. And actually, patients and carers and people who have been excluded from services, not just people who use services, have been saying this stuff, and they have been writing articles about it and, you know, trying to make noise and doing lots of incredible kind of grassroots activism. And, you know, they've sort of been ignored a lot of the time. And actually, it shouldn't take me as one consultant psychiatrist who has the ability to get published in a medical journal for people to go, oh, wow, this is amazing. You know, it's sort of really, I hope it triggers people to start actually listening to some of the things that patients and carers are saying as well. And I suppose that's where I'd, you know, like to hear from Linda, you know, because I don't want to speak for people who use services or have been excluded from services. You know, I would be really interested to hear from Linda how much, you know, it resonates or not with your experience or with other people that you've worked with.
Thank you, Chloe. And I guess with that, Linda, I wonder if we could pass to you. Remember to unmute to see what, and I know you've read the article, so what's your perspective?
It's just to say that, yeah, I moved from Hampshire to Oxford, and the minute I arrived in Oxford, I was quite a high-risk patient, forever in and out of hospital, close to death a few times with overdosing and that. And I moved to Oxford, and straight away I got referred to the adult mental health team, who said no, because I had personality disorders. So I had nowhere to turn to. So yeah, they do exclude people. They do exclude people as well that are high risk, because if you're on our caseload and something happens, you know, it's us to blame. So yes, I've been excluded as soon as I arrived in Oxford. So hence, fortunately for me, I had a GP that was willing to care and actually got me into the right services. That actually was a therapeutic community, which was complex needs in Oxford. So if I hadn't have had a GP that knew about all of that, I would have been excluded. And personally, I don't think I would have been here today.
Thank you, Linda. And you know, it's hard, isn't it, to hear these experiences. I wonder if you might have made your way to the complex needs services via the adult mental health team. Was that something that was brought up? Because I guess there were Oxford services.
I don't know. I don't know if it would have happened because I never even got an appointment. When my GP referred me to the adult mental health team, as soon as they obviously read personality disorders, they said no. And the GP contacted me and said that there's no ways I should get into the adult mental health team. And I am talking 11 years ago now, so things might have changed slightly, but I don't think it's a vast change. And I think it still happens now. That certain people are excluded from services because of either diagnosis or they're high risk.
And I'm just going to hand back to Chloe in a sense, because I guess this is a wider thing than any one service, isn't it? This is you know, something that you were writing from a sort of historic, cultural and national perspective, Chloe. Is that right?
Yeah, I think that, yeah, absolutely. I mean, this is everywhere. And I think that anybody who thinks that this doesn't occur in their service at all, I mean, probably needs to give their head a wobble, to be honest, because I don't believe that there is anywhere in the country this is not happening at all. You know, I'm sure to greater or lesser degrees, but this is so ingrained in sort of mental health service culture. But what I wanted to actually comment on was that I think that Linda's point about risk is absolutely key, because that is so much of what we do and think about in mental health services hinges on that word, which is bizarre because it's something that we know we are terrible at predicting. And that's where this idea that I talk about magical thinking comes in, you know, this idea that you can sort of say something and it's going to make it so. You know, we know from the research that risk assessment tools and checklists don't work. We're, you know, advised not to use them because they don't predict anything. You know, what we should be doing is carrying out personalised psychosocial assessments, consideration of this person's risk in the current context and what's going on. Yet everybody still does it. You know, I can guarantee that 9 times out of 10, when I look at somebody's, you know, a history that someone's taken of a patient, they will have quantified risk into low, medium and high, which we know there's no evidence for that whatsoever. And then what's so bizarre is that we then use that, you know, sometimes to help us decide to do something for somebody, but actually a lot of the cases it's designed to decide whether or not we should take restrictive measures. So if somebody's felt to be super high risk of something, you know, to themselves or to somebody else or whatever, then we might detain them under the Mental Health Act. But if we quantify somebody as low risk, even though that is really unscientific, we will tell ourselves that that is that makes it okay to exclude somebody. So because somebody you know, their suicide attempt was impulsive, or because their thoughts are fleeting, or because they can guarantee their safety, which, you know, nobody can guarantee their safety. I can't guarantee my safety. I don't mean that I think I'm going to end my life tonight, but I don't know what's going to happen if I walk out the front door. It's sort of ridiculous idea that we expect people to see the future, and also our patients to reassure us that nothing bad's going to happen. You know, that's completely the wrong way round. But then this idea as well, that if people are too high risk, then that excludes them too. So if we think you're low risk, we say, well, you don't need or deserve our help. But also if you're high risk, then you're too high risk for us to manage. So, you know, for example, things like IAPT, like, you know, sort of primary care type psychology services varies from region to region, but in many places will not see somebody if they perceive any kind of suicide risk whatsoever. Or, you know, even secondary care services will exclude based on risk, you know, too risky for this service. And that to me is just, you know, I can't get my head around it, that you would actually not see somebody because they might be risky. I mean, imagine an oncologist not seeing somebody because they had like a stage 4 cancer, you know, that is really bad and they may well die from it. I mean, it's just, it makes no sense. So we're in this crazy situation where, you know, I am referring people who may have attempted suicide or, you know, be at high suicide risk or, you know, be feeling very suicidal. I don't want to talk about who's high or low risk or whatever. But I will refer people to third sector organisations, to charities where they will be seen by trained volunteers with no medical or mental health training whatsoever, because the qualified psychologists and doctors and psychotherapists in secondary care services say they're too high risk. That makes absolutely no sense, and it's not even consistent. So whatever we think about your risk, we'll use that as an excuse to say no. And sorry, I'm getting quite fired up, but it just does my head in.
Thank you, Chloe. Your passion comes across. One of the things that you brought up, which is something I struggle with, and Linda, I'm really interested to hear what you think, but is some of the language around terms such as fleeting suicidal thoughts, or has suicidal thoughts but no plans to act, or this can guarantee you keep yourself safe, or you have capacity. So Linda, what's your perspective about this, and what have you picked up from other service users that you work with?
I think that the language is totally misrepresented, because with myself, they would say to me, and now I'm going back to Hampshire now, before I'd gone through therapy, they would say to me, have you made plans? Well, personality disorders, your emotions are up and down like that when you're on a downer, you don't have time to make plans, because it is so quick and that's it. I'm going to end my life now. I've had enough. And you don't make plans. And the minute you say you don't make plans, straight away, it wasn't intentional. You've only just done it to, cause attention to yourself or anything like that. But going through some of, now working on the other side and going through some of the patients that I'm seeing now, there was one particular patient that all she said all the time was, I just want to kill myself all the time. And it does make you think, what is behind that? And she wasn't willing to talk about it. So how far do you go into trying to get somebody to, say, what does that mean for them? Because of the language, she's only very, very young. She's 20 years old, and she's picked up, I want to kill myself. So what does that language mean for her? And even asking her that, she just says the whole time, that's all I think about. So it's trying to pick up on the language, because some of the language that even some of the clinicians use, it just goes right over somebody's head and think, you don't really understand what I'm feeling, because, you're not speaking to me as a human being. You're not speaking to me as a person. You're speaking to me from your clinical role and not understanding what I mean by what I'm saying. So I don't know if that helps anybody out there, but Chloe, I don't know if, you've come across something similar.
Yeah, I think that we have all these stock phrases and we learn them, when I say we, I'm just talking about mental health clinicians generally, not necessarily just psychiatrists or just doctors, but people working in mental health services. We sort of learn this stuff just kind of by osmosis, I think, and you see other people using it. And, I think that I've been in training for quite a long time before I learned things like that risk assessment is actually, really poorly evidenced. Because I just don't remember being taught stuff like that, but I do remember, learning things like that an impulsive suicide attempt or that a planned suicide attempt is in some way more serious. But you get taught, I think, about ticking boxes and not to see people as individual. And I think that, our sort of checklist culture and our culture of increasingly having all these different forms and things to fill out and things to check off. And although we are told that we should do individualized assessments and all that sort of thing, I don't feel that the culture actually gives much rise to that. I don't think it helps it, because when you have someone's admitted to the ward and you have like 20 different admission forms to fill in, and you have to do the risk assessment form and the "this is me" care plan and the this and the that and the I don't actually know, because I don't work on an inpatient ward, so I'm making words up, but I do know, and this is predominantly affects nurses, I think, that the amount of paperwork that does not lend itself to actually thinking about an individual person and their circumstances. And I just think it's a shame, because I think that we could do so much better. But yeah, we are taught these kind of mindless things, and this idea that doesn't even, and I could sort of understand it a bit better if I sort of thought that, I don't know, it made any sense, or it was at least born out of some evidence. But this idea that we decide that because somebody harms themselves impulsively, that somehow lowers their risk. I mean, it's literally the exact opposite is true. And I remember a psychiatrist who I sort of particularly admire speaking at some conference or other some years ago, and she said, she was very straight talking, and she said, dead is dead. It doesn't matter if it was impulsive. And I think that's what's really true. I mean, actually, who are we trying to help here? Who are we trying to reassure? We're trying to reassure ourselves about the fact that we actually can't predict the future. And I sort of sometimes say to people, like, how about if I know that we have to sort of acknowledge risk when we write notes, and we obviously have to think about that sort of thing, but try doing a risk assessment without writing the word risk, because that will focus your mind on the individual and their circumstances and what's going on and what they might do because of what factors. So yeah, I think that we just kind of learn to be mindless, and it's a real shame.
Sorry, go on, Linda. I was muted. You go first, and then I'll go.
Okay, it's just to say one of the things that I found really useful working with particular patients that are feeling suicidal or self-harm and that is ask what the feelings are before, and if they have self-harmed or been in hospital because of the attempted suicide, it's the feelings before, during and after. And it's very good for the patient to write that down themselves, because there's more chance when you're writing something down yourself that you're understanding what the feelings were, rather than you saying to somebody who writes it down and you've forgotten the minute you've walked out the door or gone elsewhere. And I found this when moving into therapy, that we wrote our own risk assessments, which is something completely different to somebody writing it for you, because all through my adult life, it was written for me and given in a piece of paper, and that piece of paper I'd get home and it would probably end up in recycling. So something that you're doing for yourself, there's more chance you're going to take more notice of, or you're going to spend more time thinking about, so that you maybe don't go as far as what you did in the previous attempt. It doesn't mean to say that it doesn't happen, but earlier on, Chloe, you were talking about the low, medium and high, and that's what ICD-11 has come out with, the low, medium and high. And it doesn't matter what intensity, if it happens, it happens. And, unless you get the correct wording put in place to try and get people to think better, it's never going to change.
Some really useful practical strategies that you've both suggested there. Chloe suggesting write a risk assessment without using the word risk, which I think is a really useful challenge for us. And Linda, that collaboration is essential, isn't it, for a true risk assessment? That there has to be that collaboration, and in terms of language, getting someone or suggesting to someone that they write some things down gives you an insight into the language that they use to express themselves, and that gives us a really good start point to have that collaboration. Certainly we're starting to try and do risk assessments without using low, medium and high. I don't think we're quite there to eradicate the word risk yet, but that's really interesting. And I think that's something that's quite a hot topic for us. I wonder if we've had quite a few questions coming in. I wonder if it would be okay for me to perhaps take a couple and pass them to you. I'm just going to. Where does the change begin when you have processes you are being told you have to complete? Are you in discussions with those who can change the format to something more user-friendly? Perhaps that's something for us as an organisation rather than Chloe, but it'd still be interested to hear your views. Certainly locally, we're doing that, trying to get rid of low, medium and high and bring in risk formulation. What do you think?
Yeah, I think that's one of the things that I talked about in the article, which is that individual clinicians have responsibility, but we can't change systems in isolation. And actually, if things are ever to change properly, then it requires sort of senior leaders and organisations to have the guts to implement change. And and it's difficult because also we get things from outside organisations. We get NHS England and CQC sort of diktats telling us that we have to have X, Y, and Z displayed on admission and that sort of thing. And I think that it's really, really difficult to change in isolation. But I think that having a culture that is an organisation that's committed to culture change, and also I think that if you have an organisation which doesn't have experts by experience as sort of absolutely core core group membership across that organization, then I think that kind of tells you something about an organization's commitment or lack of commitment to that sort of culture change. So I think that particularly those of us in a senior position do have a platform and the ability to kind of lobby our seniors and our management and present evidence that change needs to happen. And I think, that's one of the reasons I decided to sort of write it. I thought, actually, I am in a position to have these discussions. I do sit on various bits and pieces at the Royal College of Psychiatrists. Whatever your sort of area, we can all do a little bit. And I think that the biggest danger is apathy. And apathy is responsible for so much, because we all just get fed up and burnt out and think there's nothing that I can do. I can't make a difference. So I do think it's possible, whatever your role, to push and to hold people accountable, hold our seniors to account.
Thanks, Chloe. Linda, was there anything that you'd like to add to that? I suppose just before you do, the next question was to both of you, and it's very similar. What actions do you both think clinicians might be able to take to address this culture in their own teams, especially helpful to hear about actions which aren't limited to their own individual actions? So it's about the cultural change, I suppose, at a team level.
Just to go back on what Chloe's just said, it's just to say, I recall one of my last times of actually trying to kill myself, and I remember I'd seen the crisis team several times over the period of years, and they came to me in my hospital bed, and they said to me, "We're not going to see you anymore because there's nothing more we can do for you." And I was left thinking, right, that's it. There's somebody else that doesn't care about me. There's somebody else that doesn't, is not bothered if I do actually. It does succeed and I do kill myself. So I think, one, the language was wrong there. Maybe the language could have been changed around to something like, we've tried everything throughout the years and nothing seems to have worked. What can we change? What can you think that would change something? So it's putting the onus on me to try and think of what could help me. So that's where the language could have changed, rather than saying, that's it, we're not seeing you no more, and leaving me the way, you know, I'd only just come round as well, which didn't make it any easier for me. But yeah, the complete change in the system is not to give up on anybody. It's to maybe look into what isn't working and trying something new that would involve the patient as well as yourself.
So you can kind of bring that back down to that use of language, Linda, in ways, can't you? It's about working together and you know, being honest that we don't have all singing or dancing services that are going to be able to offer you a magic cure. But you know, let's think together about how you know, we might be able to help and support you develop skills to get you through difficult times in the future. Yeah. There's so many questions, so let me find another one. And I'm sorry to the audience if I'm doing them in a funny order. It's difficult to do so, but there was one that just came in. Please comment on the fear of psychiatric personnel of being struck off if they make the wrong call around risk and suicidality. I think it's important we consider this side as well, isn't it? Chloe, what are your thoughts?
Yeah, I think worries about striking off, I think, is probably a bit excessive. And I don't think people worry that much about losing their job, because actually, you know, as a clinician and as a doctor, and particularly as a consultant, rightly or wrongly, it's actually pretty difficult to get sacked, to be honest. You know, and perhaps it should be easier, but you know, I don't think that people are terribly, I don't think the worry is so much about getting struck off, but it's about being blamed and the horror of being blamed. And it's just the whole process. You know, I know lots of colleagues who have been through the process of serious incident inquiry and inquest when a patient has died, and have found it incredibly traumatic. And you might be forgiven for thinking, well, you know, how do you think it feels for the family? And of course, awful. But what you find out about, you know, a lot of these processes is that at the end, nobody's happy. The family often aren't happy because they don't feel that there's actually been justice or lessons learned. The clinician isn't happy because they feel they've been put through the ringer, but with no particular purpose. And again, I think that this honesty thing really comes into it, because we get left. And, you know, I think the fear is not so much about losing your job. It's about it's sometimes about being blamed. And, you know, you could go as far as that. But, you know, having a serious incident review find that you were negligent, or that a coroner says that you know, should have done something differently and you could have saved this person's life. And I think sometimes those processes is just really, really horrible and adversarial, even though they're not supposed to be, and traumatic. And what people end up doing, I think, is then trying to sort of retrospectively justify decisions in the wrong way. So because we feel that the only justification for, you know, having got it wrong is because we thought the risk was low, rather than we went, okay, yes, there is a risk, and this is what we're going to do together to mitigate it, then you have to sort of look backwards and claim that, yes, I definitely thought the risk was low and I would have done things differently if I thought the risk was high. And I think people just sort of tie themselves into knots. And then I also think that there is often an unrealistic expectation from people on the outside looking in of what we could have done under the circumstances. And not always, of course. You know, I just don't think that the inquest process, and particularly the serious incident review process, particularly works that well for anybody, because I've seen lots of outcomes where I thought someone should have been held accountable for this and they weren't, and why did we not pick up on this? And also plenty where I feel like something has been honed in on as the thing on which everything pivots, and families have been perhaps falsely led to believe that this one person should be to blame, and it's really not that simple. And I think that if organisations and individuals were a bit more honest and said, look, yeah, in an ideal world, I would have done X, Y, and Z, but I don't have this available to me. Therefore, people are going to continue to be at risk because I haven't got the things I need to do. But we sort of focus on individual human factors, which is so unrealistic because none of what any of us does takes place in a vacuum. So it's just all the wrong focus on everything. But I can certainly say that fear is real, and it leads to definitely a lot of the poor practice that we see. And I completely understand that from a patient and carer perspective, that's probably something that's very difficult to have sympathy with. But it's there and it's real. And lots of people, I know lots and lots of people, doctors and nurses and other clinicians who have been at some point in a position of feeling blamed or held responsible, and it doesn't help anybody. It doesn't actually help people to, I don't know, I mean, obviously if somebody has done something wrong or made a mistake or done something that they shouldn't have done, and sometimes that's clear, but I think a lot of the time it's really not clear, and we just try to distill everything and simplify it and make out like, aha, this is the one moment that everything might have made a difference. And I just think this dishonesty, this systemic dishonesty, is not helping anybody. It's not helping clinicians. It's not helping patients. It's not helping carers. It's not helping anything. I don't know if that actually made a great deal of sense. I
think what did make sense, Chloe, is the importance of thinking systemically, and that all of us are part of a system, and that's our organisational system and our community system and our national system and our global system. And we function within all of those systems, and therein lie the constraints that we grapple with on a day-to-day basis. But there also sometimes lie the dynamics and the inherent systemic anxiety that sometimes affects, I guess, the way that we try and manage, the risks that we deal with. And certainly in relation to the question there around blame, we've done a couple of surveys specific to the experiences of clinicians when a patient dies by suicide. And what came up actually is with some, there is a bit of a fear of being struck off, perhaps more amongst nurses than psychiatrists maybe. So it's a real fear. And I think that, going back in ways to Linda's point about if we can work together with patients and families in a ambience of honesty about what is possible and what isn't, and perhaps acknowledging, that we don't necessarily have all the services that we want, but what can we do together, might be a step forward sometimes. There's an interesting question. Oh, Linda, sorry, come in, please do.
Just to say, my partner's has a really good friend that has just committed suicide, and the family have turned around and said they didn't help him. They didn't help him at all. They gave up. And this is because he was a drug taker. And I think this is something that, we need to look in. Us at the crisis and home treatment team will take anybody and everybody regardless. And I think, other services, as you were talking about, Chloe, the third sector with the voluntary services and that, we won't take them because they're on drugs or alcohol or whatever. And it just brings out to the point that, people are frightened that, they're going to be blamed for it and it's going to be a risk to their jobs and everything. But I think one of the things I've learned now, being on the other side and not as a patient myself, is being so meticulous with your notes, so that if something like that does happen, you've got everything evidenced with your notes. And that if maybe you found somebody, not in a good frame of mind that day, it is noted.
Yeah, documentation is important for us. Yeah, thank you, Linda. There's a question here around sort of on the same thread, really. When talking to bed or service managers, is there anything you have found works? Is there something that helps get to an honest conversation or cuts through the exclusion language. Sorry, difficult questions, but it's about trying to change a culture where being able to exclude can be a valued skill of a frontline worker.
Threats. In all honesty, sad though it is, the only techniques that I've found have been escalating, pulling rank, getting involved as the consultant, and then people often magically start listening where they haven't been listening to a band 6 nurse, which really annoys me. That hierarchical thing. Again, it shouldn't be the case that I'm more listened to. It's ridiculous. But, starting to use names of senior managers, copying in medical directors, honestly, I just haven't got the patience. I just push it up the ranks because again, but I think that's important as well, because it goes back to my point of saying that people need to not be divorced from the front line, and people who are working further up, up the food chain need to know what it's like on the front line. And, you might be the chief exec or whatever, but would you think it was okay for you or your relative to be sat in an A&E department for 24, 48 hours because everybody says that they shouldn't be the ones to offer you a bed? Of course you wouldn't think that was okay. But somehow it's easier to distance yourself from that if you don't know the patient, you haven't seen the patient, and you're not there in the A&E department at that time. So actually, I think that there's a dual purpose of pushing things up. A, it makes things happen more quickly, but B, it helps people to see what's going on in their organisation. And look, this is people in your organisation are saying that they're not going to help this person because they're quibbling over postcode or diagnosis or whatever. And I wish that there was a different way that I found, but honestly, pulling rank is the only tip that I have.
Linda, yeah, you had.
Yeah. And then going from a patient's point of view, I've been blackmailed as well by the clinical staff. If you can do A, B, and C for so many days, then we'll let you out on a hospital visit. If you can do it for so many days, we'll organise for you to see a clinical psychologist. Well, they blackmailed me back 12 years ago, and I'm still waiting to see that clinical psychologist. Not that I need him now, but, from a patient side, it has been blackmail and not being truthful.
And I guess my query is, so is not being truthful actually lying, or is not being truthful some of the conditioning that perhaps has happened over a number of years, and so we are perhaps socialized into a culture where this is how it is. And there's a comment here from Ben Glass, one of our service user governors, who's saying the service user governors here have managed to get the trust to agree to examining exclusionary cultures as part of the suicide prevention strategy, which is obviously underpinning today, as well as reviewing self-harm agreements where they are still occurring in the trust. What next steps do you think we should take to tackle exclusionary culture at Oxford Health? And I certainly hope that this is a step. These discussions are uncomfortable, and there will be lots of different views, and we need to hear all of those different views. But what are your thoughts about additional steps going forward? And also, if anyone else has answers to Ben's question they want to pop into the Q&A, please do. Linda, can I come to you first on that one?
Sorry, it's taken me ages to unmute. Yeah, it's very difficult to know exactly what to do. I think it's to continue talking, and it's continuing putting things in place. And so it wouldn't be a case of sweep it under the carpet. Yeah, we've come up with a great strategy, let's try and use this, but it never gets put into place. And I think if you come up with something that really feels like it's worth or it's going to work, is put it in place. Because I found a lot of times it comes up, but it's never put into place.
Thanks, Linda. Chloe.
Yeah, I think that's really encouraging. I think that's brilliant, and it's really nice to be hearing more about things that are happening in different trusts, and that this idea of changing culture really is starting to filter through. But I think Linda's right. It's like with everything has to sort of come bottom up and top down, basically. So you have to have the organisation taking responsibility and saying we're going to change this, but you've also got to make sure things are changing on the ground, and that starts with, you know, education and training and seeing what's happening in teams. So I think it's probably about filtering training through to teams, but also I just, you know, it sounds like this is something that you're doing well, but I think I said earlier, I just cannot emphasize enough the importance of co-production. And actually, it is those voices of people with lived experience who have been through the things that we're talking about here, you know, have had good experiences, bad experiences, experiences of being carers, of being patients, of being excluded from services. I mean, any teaching or training session or, you know, panel discussion or anything that I've ever been involved in, it is always the person with lived experience who gets people, you know, right in the feels. You know, it's always the real narrative, someone's real experience that makes people start thinking. And, you know, because I can talk, but I'm just a doctor, so I'm not talking about specific patients. I mean, I'm not doing kind of case studies, and, you know, I'm not talking about sort of personal emotional impact. You know, it's sort of, I might not be presenting research, but it's the same sort of idea. It's presenting sort of theory and ideas and stuff. But actually, the voice of someone who has had that experience, there is absolutely no substitute for it. And anytime anybody comes back in my team from a training session or anything, you know, with something, thankfully, we see more and more and more, is that sort of co-production and that lived experience aspect is being seen as more and more important, and rightly so. So I think that is just totally key, and we have to make sure that that's the default, you know, not that this will be a nice interesting novelty, you know, like it used to be in the old days where you do like a grand round and you'd maybe like wheel the patient out to perform in front of a lecture theatre full of doctors. You know, it's working together. And you know, as I said, that is always the element that really makes people think and really makes it real. So that, I think, is the thing that on the ground and in teams is introducing training discussions. It doesn't even have to be a training package or a talk or whatever, but discussions like these in teams, disseminating information. I saw this really interesting thing, or this video, or what do you think of this? Starting discussions on the ground. It's not particularly complicated to organise. I think things like this are great, you know, putting clinicians and people with lived experience on a sort of a flat hierarchy and talking about experiences, not with some, you know, power imbalance and listen to me because I'm the doctor, and, you know, let's give the patient a novelty chance to speak as well. You know, actual proper co-production, which is not easy to achieve. You know, it's really difficult because there's always going to be a sort of power imbalance. But yeah, I mean, it's just, I think that the take-home message of the paper I wrote as well is just, how about we start listening to patients, you know, really properly, not paying lip service to listening to patients.
Linda?
I must just say, following on with that, as everybody would know, if anybody's from the crisis team listening to this, I do have a big mouth, and I will challenge anybody in my team, and even the consultant psychiatrist. I'll say, why are you doing that? You know, is that how you would have treated me? Because everybody's got to know me as part of the team. And this is why, you know, I totally agree with you, Chloe, having lived experience working within the teams is just it's so beneficial and so helpful so that the teams can understand totally on what the experience of the patient is, whether it's been good or bad.
Yeah, absolutely, Linda. I think that's so true, and it's invaluable. And you know, my perspective is we're getting there with that, with more peer support workers in our teams. You know, with the work the recovery colleges are doing and helping with, and you know, with the larger critical mass of people with lived experience wanting to contribute, and actually as well being facilitated to contribute in a genuine, authentic way, which is what, going back to Ben's point, which is what we really want to do with our you know, suicide prevention strategy and all of our other strategies. And you know, we're on the right road. We've got 10 minutes, so there's time for a couple more questions, and there's a very sort of honest one here as well, again from a clinician perspective. For me as a clinician, it's not a fear of consequences in terms of career or being blamed. It's something much more integral to me, and about living with the question and the guilt that I missed the risk to the patient and I could have done something different to their death. I agree it is soothing to write no plans or intent, but I am safeguarding myself as a human being and not protecting my job or organisation. And reading that, I feel quite moved, and I think that we do need to have these conversations, and we also need to have conversations recognising the lived experience of staff, and that lived experience is all of us, isn't it? It's our service users, carers, relatives and staff, and you know, we're all important there. Right, a couple more questions. It seems to me that the power imbalance is very related to the obsession and attachment to medication within society. If you can prescribe, you're automatically seen as God-like by both patients and other staff and are given a voice. I don't know whether either of you want to comment on that. Linda, you look like you did.
Yeah, medication was the world to me, and every medication I could get. Yeah, so anybody prescribed me anything, you were my best mate. But actually, you know, if you can explain to your patient what the medication that you're getting could damage, might not be helpful, and might be the wrong medication, is much more important than just writing a script out. But yeah, if I could get it, I would get it. And, you know, it was totally wrong, the prescriptions I got.
Chloe.
I mean, I would like it if just one person would think that I was godlike. That'd be great. You know, my world is not one in which people think psychiatrists are godlike. I mean, maybe some of us think we're godlike, but yeah, I've not got the experience of being treated that way. But yeah, I think, yeah, it's interesting, isn't it? Because medication is, you know, we have this sort of, I think, sort of slight myth about this divide in mental health where psychiatrists are seen as being really wedded to this medical model. And it's really interesting because I don't know what the medical model is, and I don't know any psychiatrist, and I know lots of them, who thinks that mental illness is something purely biological that you only treat with medicine. Like, I don't, this argument and this divide is not something I see in practice. I sort of slightly think that maybe it's been invented by Twitter. But certainly I think not just in psychiatry, I think in society, yeah, we have this false idea that you can quick fix problems with a drug or an operation or whatever. And we really don't like the idea that it might be more complex, or, yeah, I mean, far from spending my life putting people on medications, I think I probably spend an awful lot more time explaining more to other doctors, to be honest, than to patients, why, no, I really don't think I do have a medication that's going to sort this out. I have some things that might possibly help a bit as a tool in the armory, but I haven't got a miracle. But yeah, I think that is our society in general. You know, people want a quick fix, and we as clinicians are as guilty. You know, we want to make something better and send it away. Yeah, it's difficult, and I wish people sort of understood the nuances more, and you know, the importance of all of the different roles in services, if they're working as they should.
Thank you, Chloe. So just a couple more comments. There's one here that's similar to the point I made earlier. There are a lot of assumptions in these comments about what professionals think and feel, rather than seeing us as people in the same way that other people are asking to be seen as people. So that's talking about the lived experience of staff, which I do think is important. As a carer of a relative, we had to fight for everything when it came to getting care. We were lucky to get an incredible social worker who fought for our relative too. She cared, and I would say that saved my relative's life many times. My question is, can we get the compassion back into the treatment? And I suppose I'd quite like to end on that one a bit, and just, you know, notwithstanding the importance of having difficult, challenging conversations like these, it's also really important to remember that none of us come into this profession because we don't care and we're not compassionate. We all come into it because we do care, and actually we are compassionate. And it's a difficult place to be. It's a difficult system to work within. It's an under-resourced system. But certainly in my job, I'm fortunate to work with people across the whole organisation, and I'm frequently just blown away and humbled by the huge level of compassion and care that people extend to their patients and their service users and their families. Chloe, you stuck your hand up quickly.
Yeah, just one thing, just sort of related to that, is that I know that I am extremely critical of my own profession, but I think if you read the article, I hope that it will also sort of demonstrate that I think that sort of burnout and compassion fatigue and moral injury are a lot behind all of this. And actually, I think you're absolutely right. I think the vast majority of people go into this job for the right reasons. It's certainly not for fame and fortune. And I think that compassion can get beaten out of us. So when I sort of talk about we and the reasons for, I'm not, you know, you can't speak for everybody, but I think that lots of things are behind this, and it's not necessarily about criticizing people as individuals. I think that this is a culture that creates us and creates problems. So yeah, it's I absolutely agree. It's far more nuanced than that, and I don't want people to think that you know, that I'm here to sort of say all of us are crap.
And I don't think that has been taken, because the comments in the Q&A are very rich and grateful, I think, for us being sort of bold enough to you know, to have this conversation. So I hope we find ways of continuing to challenge each other to have these difficult conversations, because I think that the outcomes can be really valuable, and we can take these small nuggets away. Shall I try and do a risk assessment without risk? Let me really think about the language I'm using with people. Am I truly listening? Do I know that their language is the same as my language? You know, these simple things that we can take away and try and put into our practice, but also come together as teams to help each other through jobs we want to do well, but are quite difficult. So Chloe, thank you for taking the time to be with us today. Linda, thank you again for being here and for everything else that you do for us here in Oxford Health. It's been a pleasure and a privilege, and thank you everybody for joining us. Someone has asked for the transcript of the chat to go on to the intranet with the recording of the webinar, so we'll look into making that happen. And thank you very much.